Dear Pure Urology friends, good evening one and all. As you all know, Pure Urology is doing every other day or alternate day surgical technique based presentations in urology. Today's interesting subject is something related to tissue engineering, which is not a common subject. Every surgery need not be suturing, knotting in the future. It can be tissue engineering. I have little experience in tissue engineering when I have done 10 years back. Stress incontinence, the biceps muscle of the patient was taken and done culture with the myoblasts, and they are injected after 3 weeks into the urethra in female patients. This used to take time. Fortunately or unfortunately, that study concluded and it could not come into practical. After some time, few years back, I came to know that Dr. Surya Prakash, who is Association of Southern Urology Secretary, and my colleague urologist in Hyderabad, he is also urethroplasty interested surgeon, reconstructive surgeon. He is working with Dr.AKIO, who is our speaker. And in the last SIU meet we met, and we thought this is already on research and is giving good results. I thought today we will take up this something related to the cells which are which has to be implanted in the buccal mucosal cells to be implanted in the urethral stricture. So let me introduce Dr. AKIO HORIGUCHI. Before I introduce him, I'll say hello to both Surya Prakash and AKIO. Hi. So Dr. AKIO, I have seen your CV, amazing. I will read it anyway. You have been very enthusiastic youngster from Japan. Very few people I have interviewed from Japan. As Indians, we always appreciate Japanese urologists and Japanese culture of hardworking and discipline. Who is your mentor in urology, and how you developed interest in reconstructive surgery?
Actually, I have been trained as a general urologist, including laparoscopy and endoscopic surgery. And actually, I learned reconstructive urology by myself by watching the Indian urologist, reconstructive urologists such as Kulkarni, Dr. Kulkarni. He is my mentor on YouTube. I learned his technique on YouTube.
Very good. Your favorite surgeries are?
My favorite surgery? Yes, I like urethroplasty because my main focus is urethroplasty.
How is the surgical? I mean, what is the curriculum of surgical training in Japan? We consider MBBS, MS, then MCH. This is the order where we become super specialists. How is the training in Japan? Actually, surgical training.
Actually, we learn general almost all area of surgery in the first 6 years. Thereafter, our subspecialty began after 6 years.
Okay. So you are working in which hospital now? Yeah, I heard you are working in National Defense College.
Yes,
It's a government hospital.
Yes, military-related hospital.
Do you have private practice also in Japan apart from government practice?
Both. I'm doing both private and offshore practice. Both. Thank you.
Yeah, that's nice. So to start with, today video-based surgical presentation on PURE is transurethral implantation of buccal mucosal cells, a novel therapeutic approach for anti-urethral stricture by Dr. AKIO HORIGUCHI from Japan. He is Associate Professor and Reconstructive Surgeon, Department of Urology, National Defense Medical College, Saitama, Japan. Board of Director, Genitourinary Reconstructive Surgeon. This is an important group, GURS. Director, Department of Wound Reconstruction, National Defense Medical College. Certified cancer treatment doctor in Japan and active member of SIU, AUE, and EAU. He has expertise in treating urethral strictures and has performed more than 1,200 urethroplasties. Selected as best doctor in Japan for 3 consecutive terms. That's great. In 2017, awarded IJU Reviewer of the Year 2015. He has authorized more than 10 books related to urethral stricture. Invited faculty for many national international conferences, has more than 80 publications. Before I hand over the program to you, how both of you got connected in this field? What was Surya Prakash? How did you get this research thing into? Who has initiated this research along with AKIO?
Yeah, in my talk, I will introduce our correlation, the beginning of our correlation.
Okay, then over to you. then we will have continuous presentation at the end. We'll have a brief discussion about the results. What is the future of these type of cells? Okay, over to you
Sure.
then.
So may I start my talk?
Yeah, please.
Yes.
Thank you.
Can you see my slide? Okay.
Yes, please.
Yes, thank you. Thank you, Dr. Chandra Mohan, for very kind introduction. It is a very great honor to have this opportunity to present here. I'm very happy. Today, I'm going to talk about a novel therapeutic strategy for anterior urethral stricture using transurethral implantation of buccal mucosal cells. So, before starting my talk, let me introduce myself because this is the first talk in India. I'm a reconstructive urologist working at National Defense Medical College, belonging to the Ministry of Defense of Japan. My institute is one of the high volume center of reconstructive urology in Japan. And we perform about 150 urethroplasties annually. I have served the board of director of Society of Genitourinary Reconstructive Surgeons until this October. The National Defense Medical College Hospital is located in Tokoroza City in Japan, in Saitan Prefecture. Tokoroza City is very close to Tokyo, the capital of Japan. It is about only a 1 hour drive from Tokyo. And Tokoroza City was the site of Japan's first airfield. It is very famous fact. And Tokorozawa Aviation Memorial Park is located right next to the National Defense Medical College. In addition, as shown on the right panel, the Saitama Save Lions, a very, very strong Japanese professional baseball team, is based in Tokorozawa City. We sincerely look forward to welcoming you all to Tokorozawa City. So by the way, what do you think this is? You may not believe it, but this is a typical Japanese curry rice. Indian cuisine, especially curry rice, is very popular in Japan. However, the Japanese curry rice is quite different from the real Indian curry. A Japanese curry store opened in New Delhi in 2020. I hear that Japanese curry rice is also popular in Indian people. It's very interesting. The number of Indian immigrants in Japan has been increasing recently, and the number of Indian restaurants is also increasing. This is an Indian restaurant very close to my house, and many Japanese people, including me, enjoy original Indian food here. I also eat curry at this restaurant every week. With the increased number of Indian restaurants, we Japanese can enjoy not only curry rice, but also other Indian cuisine such as biryani and dosa, everything. But unfortunately, I have never been to India, so I really hope to travel to India in the near future.
We will invite you for the surgery to India.
Thank you. In the near future, and enjoy authentic Indian cuisine. So this is the beginning of my talk. So let's start my talk. This is today's agenda. First, I'll be talking about the problem with current urethral stricture management. Urethrotomy and dilation is the most common procedure for urethral stricture, but it is associated with a high rate of stricture recurrence. So next, I'll be talking about how to prevent urethral stricture recurrence. Local injection of antifibrotic agents have been reported. Although these agents are effective in preventing stricture recurrence to some extent, but they are not still accepted as standard treatment. So on the other hand, we are focusing on cell-based therapy as a new strategy for preventing stricture of urethral stricture. This is my today's main topic. So finally, I'll be talking about the possibility of cell-based therapy for urethral stricture using oral mucosal cells. So first, I'll be talking about the problem with urethral stricture management. This is the introduction of urethral stricture management. Urethral stricture is a common and challenging urethral urological issue. This could be same in India. It is characterized as a constriction of urethral lumen by spongiofibrosis due to various etiologies such as trauma and instrumentation. Urethral stricture can cause not only lower urinary tract symptoms, but also urinary tract infection, renal dysfunction, and sexual dysfunctions. This slide shows the epidemiology of urethral strictures. The bulbar urethra is the most common site of urethral stricture, and the etiology of urethral stricture vary widely by region. Idiopathic and iatrogenic strictures are common in the United States. This is same in Japan, while traumatic stricture is more common in India. The etiology of stricture vary greatly depending on the patient age. This is data from Italy. In younger patients, idiopathic stricture is the most common. In contrast, iatrogenic strictures due to such as transurethral surgery is common in patients over 60 years old. The aim of urethral stricture management is to retrieve of normal voiding and make patients free from any instrumentation. The purpose of treatment should be cure of stricture, but not palliation of symptoms. We urologists should keep this concept in mind. There are two options, as you know, there are two options for the management of urethral stricture. One is transurethral procedures such as dilation and DBIU on the left panel, and the other is open surgical management, that is urethroplasty. Although recent urethral stricture guidelines recommend urethroplasty as the gold standard treatment because of its high success rate. However, DBIU and dilations are most common and widespread procedure. Is these DBIU dilation really effective for urethral stricture? The answer is no. This is a STEEP camp performed prospective randomized study performed in 1997 using in 210 patients with urethral stricture. This study was performed to compare the efficacy of dilation with DBIU. Actually, there was no difference in the efficacy of DBIU and dilation regarding stricture-free rate. It is defined as the ability to pass a 60 French urethral catheter. The therapeutic effects of DBIU and dilation are equivalent, and either may be selected. This study shows a relationship between stricture length and stricture-free rate. The stricture length is a very important factor for the success. So at 12 months after DBIU dilation, the stricture-free rate was 60% for short stricture. It is shown in group A. On the other hand, stricture-free rate was only 20% for long stricture, shown in group C. There is very big difference. So when we see the result at 48 months after DBIU and dilation, the stricture-free rate for 2 to 4 centimeter group B decreased only 25%. So based on these results, recent guidelines consistently state DBIU or dilation should not be selected for long stricture greater than 2 centimeter. The efficacy of DBIU and dilation depends not only on the stricture length but also on stricture site. According to the Pansandro paper in 1996, the stricture-free rate of DBIU was 42% for bulbar stricture. On the other hand, it was only 60% and 11% for penile and penobulbar strictures. when DBIU was repeated, no stricture, no penile stricture, no penile stricture were success. So there's no success in penile bulbar strictures. This difference in success rate between bulbar stricture and penile stricture is due to their anatomical difference in the corpus spongiosum. As shown in the left panel, the thickness of corpus spongiosum varies depending on the site of the urethra. It is thicker at the bulbar urethra and thinner at the penile urethra. In other words, blood supply is weaker in the penile urethra, which is thought to be the reason for the lower success rate of DBIU in penile stricture. Recent guidelines also state DBIU should not be performed for penile urethral stricture. Does it make sense to repeat DBIU and dilation in recurrent stricture? The answer is no. This figure shows the stricture-free rate after the first, second, and third DBIU. After the first DBIU, 70% is stricture-free at 3 months, and 35 to 40% remain stricture-free at 48 months. On the contrary, the third DBIU is of no value, no patient successful. Recent guidelines also stated that DBIU dilation should not be performed for recurrent urethral stricture. So taken together, according to the recent guidelines, the use of DBIU dilation is justified only for favorable urethral stricture. Favorable urethral stricture is a stricture meets all of the 5 conditions on the slide. That is, bulbar stricture, non-traumatic stricture, short stricture, single stricture, and no history of prior treatment. Favorable stricture need to fulfill all of these conditions. If one or more condition is not satisfied, such as traumatic stricture, long stricture, and recurrent stricture, these strictures are considered unfavorable stricture, and DBIU dilation cannot be recommended and should be managed by urethroplasty. In most cases, the efficacy of DBIU dilation is only temporary, and recurrent stricture is inevitable. Therefore, DBIU dilation is often repeated. So, repeat DBIU dilation is not only futile, but also increases stricture complexity. This slide shows my paper published in the Journal of Urology showing negative impact of DBIU dilation. Figure A and B, figure A and B, and figures C and D shows urethrography before and after repeat DBIU dilation for the same patients. You can see the strictures become complicated after repeat treatment. Repeat DBIU dilation complicates urethral stricture and also negatively affects the surgical outcome of subsequent urethroplasty. On the left panel, Ben Breyer reported that prior DBIU was a significant predictor of restricture after urethroplasty. On the right panel, Carty reported the patient with history of prior DBIU history has significantly lower success rate of urethroplasty. Therefore, it is critical to avoid repeat DBIU dilations because it is less effective and risks damaging of the urethra. It is clever, it is wise to opt for urethroplasty. So, urethral stricture is rarely treated appropriately. The answer is, unfortunately, the answer is no. Despite the lack of efficacy of DBIU and dilation, the obvious risk of complicating of the stricture, unfortunately, urethroplasty is actually still underused. This is evident from the nationwide surveys of the practice pattern of urethral stricture management reported from various countries. This is a report of nationwide surveys of practice patterns of anterior urethral stricture performed on 431 certified urologists in the United States. Most urologists treat 6 to 20 cases of urethral stricture per year, most of which were treated with DBIU or dilations. Only a few urologists performed urethroplasty as a routine procedure. And in addition, 74% of certified urologists continue to do, 74% of urologists consider urethroplasty as a last resort when DBIU dilation failed. This is another nationwide survey of 181 Dutch urologists regarding practice patterns for anterior urethral stricture. The question was, how do you manage 3.5 dense bulbar urethral stricture? As I shown before, as I shown earlier, this type of stricture is unfavorable stricture. So the most successful procedure was urethroplasty, but 49% of responded answered they choose DBIU or dilation. The next question was, how do you manage recurrent 1 cm bulbar stricture after 2 failed DBIUs? This is also an unfavorable stricture cases, but 20% of responded answered they would still choose DBIU or dilation. So all of the nationwide surveys, almost same results are reported. Most urologists treat urethral stricture with DBIU dilation. Most urologists have little experience with urethroplasty. And most urologists believe urethroplasty should be proposed only after failed DBIU dilations. As a result, DBIU dilations are overused and urethroplasty is underused. A similar trend has also been reported in Japan. This is a nationwide survey on the treatment of urethral stricture due to pelvic fracture urethral injury. Because traumatic urethral stricture is rare, about 60% of Japanese consultant urologists experienced less than only 3 patients with urethral injury for their career. In principle, traumatic urethral stricture should be treated by urethroplasty, but the reality is the most traumatic stricture is treated by DBIU or dilation. We recently evaluated whether patients referred to our center are treated before referral. More than half of the cases were found to have been inappropriately treated with repeat DBIU and dilation before our referral. Right panel shows the urethrography of referred patients with unfavorable stricture. They were all treated with inappropriate DBIU and dilations. This is a comment of Professor Mandy, one of the most famous world reconstructive authority. Many of patients with anterior urethral strictures are seated for urethroplasty, but they are actually undergoing repeat urethrotomy and dilation without any hope of cure. This is a reality in the treatment of urethral stricture. This graph truly represents the ideal and reality of treatment methods for urethral stricture. Ideally, 95% of urethral stricture should be treated by urethroplasty. However, in reality, 95% of patients were treated by DBIU or dilation. There are a couple of reasons why urethroplasty is underused. First, urethroplasty is technically more demanding. Second, urethral surgeons are required to master a variety of surgical techniques, and it takes a long time to acquire expertise. As a result, most urologists continue to do urethrotomy and dilation, despite predictive failure. This is a report by the American Trans group on regarding the learning curve for urethroplasty. This paper states that at least 100 cases are needed to achieve the same success rate as the experts. Urethroplasty is a very difficult procedure for beginners. This is a series by Dr. Barbagli of Italy, one of the world-leading authority regarding buccal mucosal urethroplasty. He reported that a surgical outcome of urethroplasty has not yet reached to a plateau, even with 600 cases under his experience. And the surgical success rate continues to improve. So based on this background, Professor Mandy stated physicians who do not perform regularly urethroplasty should refer their patient to reconstructive specialist. The AUA guidelines also stated the surgeons who do not perform urethroplasty should offer patients to reconstructive specialists. So now we are faced with the need to improve surgical outcome in the treatment of urethral stricture. I think there are two options for improving the outcome of urethral stricture. One is to popularize urethroplasty, and the other is improve the effectiveness of DBIU and dilation. As mentioned above, the former is most effective because the urethroplasty has very high success rate, but it is actually difficult and not realistic because the urethroplasty is very difficult and a large number of surgical expertise is required. So therefore, the latter option is simple and straightforward. However, it requires some innovative technological development. So next I'll be talking about adjuvant local therapy in preventing stricture after DBIU and dilation. Here is an illustration of cross-sectional view of the urethra treated by DBIU in the left panel and dilation in the middle panel. In both strategies, urethral lumen is enlarged immediately after treatment, but most of the urethral mucosa is defected. After treatment, urethral mucosa regeneration and fibrosis contracture begin simultaneously. Contraction and fibrosis stops only after urethral lumen is covered by regenerated epithelium. So, for successful DBIU dilation, epithelialization of urethra must be completed before fibrotic contracture develops. I think there are two options for preventing recurrent stricture. One is periurethral injection of antifibrotic agents that prevents contracture, such as local injection of steroid and mitomycin C. These effectiveness have been reported. And this is a recent systematic review and meta-analysis of 7 studies in 365 participants regarding the efficacy of local steroid injection after DBIU. The application of local steroids appeared to reduce the recurrence rate and time to recurrence. This is another meta-analysis regarding the efficacy of local injection of mitomycin C in very large 892 participants. It is also shown the addition of mitomycin C in addition to DBIU significantly reduced stricture recurrence. However, although the local therapy with steroid and mitomycin C has been reported to be effective, the level of evidence remains low. So, therefore, AAU guidelines still do not recommend this treatment as a standard of care. So, more robust randomized trials are necessary to validate these outcomes. So, The device that recently received a lot of attention is Optilume. Optilume is a paclitaxel-coated urethral balloon dilation. This inhibits fibroblast growth and scar formation. This is a report on the recent results of Robust 3 randomized trial of Optilume. As shown in the left panel, the success rate of Optilume was 75% at 6 months. This is significantly higher than the success rate of control dilation group. So, this is today's main topic. I'll talk about the cell-based therapy for urethral stricture. So, the other option for preventing stricture recurrence is to promote urethral epithelialization. I think cell-based therapy is an attractive technique. So, oral mucosa is frequently used in urethroplasty and could be an excellent material for use in cell-based therapy. As you know, oral mucosa graft, especially buccal mucosa graft, is considered as the best urethral substitute, and it is widely used for urethroplasty. Urethral stricture guidelines, major guidelines, SIU, AUA, EAU, all guidelines consistently recommend to use oral mucosa graft as the first choice in substitution urethroplasty. There are a lot of advantages of oral mucosa graft as a urethral substitute. It is very easy to harvest, very tough and resilient to handle, very easy to inoculation, accustomed to wet circumstances, and it is resistant to infection. So, my very close friend Dr. Nikolavsky from New York, he has developed a novel and revolutionary method for transurethral grafting of oral mucosal tissue in the urethral stricture. He used a rabbit urethral stricture model and he performed DBIU and then injected minced, very fine, very minced small pieces of oral mucosal tissue into the urethra with fibrin glue as a scaffold of the graft. The left panel shows a photograph of minced oral mucosal tissue, and the right panel shows the urethrography before and after treatment, and the histological images of urethra after treatment. As shown by the arrows, it is confirmed that injected oral mucosal tissue has successfully engrafted. I think this is very truly a revolutionary treatment. After knowing Dr. Nikolavsky's technique, I have been exploring the possibility of cell-based therapy for urethral stricture using oral mucosa. It was a time when I met Dr. Abraham, as shown in the left panel. He is now my very good friend. Dr. Abraham is a surgeon from India and is currently working as a faculty of Center for Advancing Clinical Research at Yamanashi University in Japan. He has developed various regenerative medicine techniques. In particular, he is the inventor of a novel urethral stricture treatment, BEES-HAUS technique. This is today's main topic. BEES-HAUS technique stands for a transurethral treatment of urethral stricture using culture oral mucosa cells. We have been working together since then. And this slide shows a scheme of BEES-HAUS technique. The first step of BEES-HAUS technique is to harvest small amount of buccal mucosa tissue about 2 weeks before treatment. Harvested buccal mucosa tissue is enzymatically digested, and buccal epithelial cells were expanded in the laboratory. The cultured buccal mucosa cells are finally encapsulated in scaffold and brought to the operation room. The stricture was treated by regular ordinary DBIU, and a Foley catheter is placed in the urethra. And the buccal mucosa, the cultured buccal mucosa cells suspended in a liquid scaffold are injected around the urethral catheter. The urethral catheter is placed for about 3 weeks, and the patient starts boiling. So my very close friend, Dr. Surya, he performed a pilot study of BEES-HAUS technique in 6 male anterior strictures. The left lower panel shows the cultured oral epithelial cells from harvested buccal mucosa and successfully engrafted oral epithelial cells inside the urethra. The right lower panel are representative pre- and post-procedure urethrography, showing enlarged urethral lumen after BEES-HAUS procedures. These figures show the urethral stricture was healed by cultured buccal mucosa cells engrafted inside the urethra. Very interestingly, all of the patients included in this study had stricture longer than 2 cm, and 3 of 6 had already been previously treated. That is, all of the patients included in this study had unfavorable stricture. So, in other words, the possibility of achieving stricture-free status by conventional DBIU alone is extremely low. However, in this study, 4 out of 6 cases, 66% of patients achieved stricture-free. I think this is a very remarkable, amazing results. So actually I reviewed this paper, and when I reviewed this paper, I was so impressed and write an editorial comment. I felt that this BEES-HAUS technique was a truly revolutionary method of stricture management. This is truly transurethral urethroplasty. So I started animal experiments in our facility to validate BEES-HAUS technique. So this is for proceeding to clinical trials in Japan. So I'd like to show the, unfortunately I have no clinical data, so I'd like to show the result of this verification experiment in rabbit urethral stricture model. This slide shows a schematic illustration of animal experiments. We also use rabbit animal stricture model. The first urethral stricture was created by electrocoagulation, and small buccal mucosa tissue was harvested. Buccal mucosa is harvested and oral mucosa epithelial cells are prepared. Thereafter, ureterotomy was performed, and cultured buccal epithelial cells were suspended in thermoreversible gelatin polymer (TGP) and injected inside the urethra. 1 week later, urethral tissue was collected and histologically examined for the presence of engraftment of oral mucosa cells. So here is the actual experimental data. First, before starting experiment, retrograde urethrography was performed, and we confirmed there's no pre-existing stricture. The male rabbit urethra was injured by electrocoagulation with the spherical monopolar electrode cautery shown in the slide. We coagulate inside the urethra at 40 watt for 30 seconds. The urethra was electrocoagulated and immediately evaluated with urethrography and pediatric urethroscopy. The arrow in the right panel indicates the area injured by electrocoagulations. After 2 weeks, cystourethroplasty was performed, and the creation of urethral stricture was confirmed. Buccal mucosa tissue was harvested from the rabbit buccal mucosa after urethral stricture was confirmed. We used biopsy punch shown in the left panel. It is used for harvesting buccal mucosa tissue, and the circular piece of buccal mucosa approximately 8 mm in diameter was harvested. The harvested buccal mucosa tissue was transported to the cell processing center, and the buccal mucosa was enzymatically digested by using acutase, and collected epithelial cells were isolated and cultured for further 7 days. The buccal mucosa cells were then mixed into TGP scaffold for transplantation. What is TGP? TGP scaffold is a very unique property of soil-gel transition depending on the surrounding temperature. It is liquid at low temperature in the cell suspension kept in ice. In contrast, once the TGP injected inside the urethra, TGP become gel immediately after injected into the urethra. Therefore, buccal mucosa epithelial cells can stay inside of the urethra. And this is the photograph of urethrotomy and injection of TGP with buccal mucosa cells. Urethrotomy was performed by a cold knife as shown in the left panel. This is the same knife as the human use. And confirmed opened urethral lumen by cystourethroskop as shown in the middle panel. Thereafter, 6 French Nelson catheter was placed inside the urethra, and buccal mucosa cells suspended in TGP scaffold was injected periurethral. The Nelson catheter was left placed for 1 week, and 2 weeks after treatment, the rabbit was sacrificed and the urethral specimens were harvested and sent for the pathological analysis. This slide shows the representative histological finding of harvested urethral specimen. The HE staining at the dot line in the left panel is shown in the right panel. The area enclosed by the yellow line is normal urethral epithelium. On the other hand, the area enclosed by the white line is urethral mucosa. So this is caused by the urethrotomy, urethral defect caused by urethrotomy. And then this is covered by multi-layered squamous epithelial cells. This is presumably derived from transplanted buccal mucosa cells, but it is necessary to confirm by immunohistochemical analysis. So the next step, we confirmed whether the squamous epithelial cells inside the urethra was truly transplanted buccal mucosa cells. To confirm this, we performed immunohistochemical analysis using CK40 antibody and anti-GATA3 antibody. What is CK14 and GATA3? CK14 is a marker for buccal mucosa cells, and GATA3 is a marker for urothelium. And this slide shows the representative histological findings. And figure D, G, J shows the area of urethral mucosa defect caused by urethrotomy and thereafter covered by squamous epithelial cells in representative 3 rabbits. As shown figure EHK, the CK14 was positive on the lumen covered with the squamous epithelium. On the contrary, as shown figure FIL, the GATA3 was negative in the region positive for CK14. These results strongly suggest transplanted buccal mucosa cells were successfully engrafted on the urethral defect. And this result has just been reported recently. So this is the last slide. In conclusion, successful engraftment of autologous buccal mucosa cells was confirmed based on immunohistochemical biomarkers in rabbit urethral stricture model. Our result may support the surgical outcome BEES-HAUS technique for male urethral stricture. and cell-based therapy such as the BEES-HAUS technique could be an attractive therapeutic option for urethral stricture. Further studies in larger population will clarify the clinical efficacy of BEES-HAUS techniques in the future. Thank you very much for watching. Thank you.
Thank you very much. So I understood a little bit of it. First, let Suryaprakash say a few comments, what work he has done on this. Then I will ask the basic questions. Over to you, Suryaprakash.
Thank you, Chandramohan. Thank you, Dr. Horiguchi, for a wonderful talk.
Thank you.
It was very clear what you have done. And I really appreciate you for sticking to the subject of urethra and doing a commendable work in Japan. Of course, you are now an internationally famous urethral surgeon. Dr. Chandramohan,
Yes.
see, we have a common friend. He has shown Dr. Samuel Abraham.
Okay.
So he has got an Institute of Regenerative Medicine. Basically, he's an Indian from Tamil Nadu. He did MBBS in Tamil Nadu, then migrated to Japan, did cardiac surgery, and developed interest in regenerative medicine. Now he's more of a scientist rather than a cardiac surgeon.
Okay.
So he also has got an office in Chennai.
Okay.
When I was in Narayana Medical College, so we had a discussion and we started work in Nellore Narayana Medical College.
Okay.
So the work what Dr. Horiguchi has described, the patients from Narayana were subjected to this procedure. The cells were cultured in his lab in Chennai. 2 weeks later, the cultured cells were brought to our operation theater where we did a VIU and then injected the cells. And rest is all what it is published, International Journal of Urology.
Yeah.
So Dr. Horiguchi and me are common friends, Dr. Samuel. So the clinical study, then they extended to animal study in Japan. Yeah, you're telling.
So, AKIO, then I will
Yes.
ask questions to both of you. See, what primary cell regeneration capacity is important whenever you can see what are the cells in the body. Do you have any knowledge apart from buccal mucosa where they can be utilized within 3 weeks for the purpose of injecting or utilizing in regenerating of local area of the tissue? Is it the cells regenerative? How much buccal mucosal cells multiply in 3 weeks double or 2 weeks double? How much time they will take?
Yeah. Can I take this?
AKIO, did you understand my question?
So can you? I'm
I'm
sorry.
asking what type of cells can be utilized for this type of injection therapy. Does it depend on the multiplying capacity of the cells? Like you have bone marrow, you have buccal mucosa,
Yeah, yeah,
you
yeah. I
have
know.
muscle, you have skeletal muscle, you have a smooth muscle. Can all these can be expected to regenerate fast to produce the basic lattice?
In this application, only cells that has property of epithelial cells is only applicable. So I don't think this skeletal cells or something is not used for this application. Buccal mucosa is very good candidate for the use for this treatment.
If I ask you some intestinal mucosa by chance, if you take as a layman, I'm asking. I don't have knowledge about this cell culture. If you take the intestine, small intestine as a culture or large intestine cells as culture?
No. Dr. Surya, can you have?
Yeah, Chandramohan, see, why a buccal mucosa is preferred over other tissue in urethroplasty? Because it is easily accessible. It stays in a wet environment. That is the reason it is preferred over a bladder mucosa or a colonic mucosa, and it has become a standard of care in urethral surgery. That is the reason we preferred harvesting cells from the buccal mucosa in our scenario. So to talk you about what all the cells can be used, here we are using a tissue from which can form an epithelium. We are not using a mesenchymal tissues like a skeletal muscle or adipose tissue, though there are some studies using adipose tissue also. So we want a cells from a tissue which can form an epithelial lining over the urethra.
One more question. Once the epithelial lining forms, there are other layers, not only the epithelial lining. There is supportive lamina propria, the basal layers will be there. Will they form with this type of, when the cells grow, will they form any structure, or the only cells will be there?
This is a single layer. We are not reconstructing a multi-layer like epithelium, subepithelial connected tissue. It is very difficult to culture or do a regenerative medicine of that kind, multi-layer structure. Though there are some studies, clinical laboratory studies, which are not coming to clinical practice. As of now,
another possibility is producing cytokines and growth factor from the buccal mucosal cells. I and Dr. Abraham examining the production activity of growth factors such as IGF, insulin growth-like factor, which is essential for the growth of epithelial cells. Buccal mucosal cells produce a lot of growth factors, very good for the epithelialization.
Yeah,
Dr. AKIO, we can add about 3D culture, what you have done.
Yes.
So they have done 3D culture in their laboratory, Chandramohan.
Yeah. Recently, I have heard from one lady, Dr. Elisa, which showed that cut open the entire urethra. She has taken a lot of fat tissue, made culture, and multiple times injected in submucosa, and then closed over the catheter by massaging it. I mean, it is subcutaneous, submucosal tissue she injected. She has given talk. She says that results are. She is advertising also a lot about that. I have asked about the papers. I don't think she has published anything like that. Injecting of the adipose tissue into the submucosal urethral stricture, but opening the urethral stricture and then injecting with syringe, lot of multiple injections and spreading with the hand. I don't know. Is it the same mechanism?
This is different. Here we are culturing. Yeah, Dr. AKIO. Yeah.
Yeah, it's quite different because our aim is epithelialization. Yes, just only epithelialization of buccal mucosal cells inside the urethral lumen, not to regenerate.
Which instrument, Surya Prakash, you have used to inject this culture into the after doing OIU? Is it like deflux injection type of instrument?
You see, what we did a wide urethrotomy using a 21 French sachets urethrodome. Then we placed a 14 French silicone catheter. So we inflated the balloon, give a light tug to the bladder neck so that the material, the cells, doesn't go into the bladder.
Okay.
Using a 17 French cystoscope and using a 5 French ureteric catheter through the 17 French, we go to the distal edge of the urethrotomy site.
Okay.
Then under vision we inject. I think I have showed in one of the conferences. With a ureteric catheter, we inject. These are transparent material which consists of cells in TGP. TGP, as Dr. HORIGUCHI said, it is a thermo-reversible gelation polymer. It has got reverse physical properties. That means if you, at the body temperature, it becomes solid. If you heat it, it becomes solid. If you cool it, it becomes liquid. So it is brought to the laboratory in a liquid form in an ice pack mixed with cells. So it has to be injected immediately because even at room temperature, it becomes solid. So we take it into a syringe, which is a syringe filled with TGP and cells.
So by the side of the Foley's catheter, you go with 17 French with urethric catheter.
Yes.
You put there a little bit, prick it, and then inject with syringe.
No pricking. No pricking. We just inject over the catheter. It forms a layer. Because we have already created a raw area.
Like something like fibrin type of layer over the injured cut urethra. It will form a small fibrin and then it will stay there for a few hours. After that, it will multiply over that. That is the concept.
Yes. We don't inject. We have already created a raw area. In that raw area, we inject the cells. The cells in the TGP, they migrate and then attach to the raw area, to the extracellular matrix. And they multiply. We have shown that when initially we harvested the cells, they were to the tune of...
How much buccal mucosa you have taken for these cells to regenerate?
1 centimeter buccal mucosa.
Local anesthesia and you have sent.
Yes. And we have multiplied to the tune of 10 lakhs. The cells are cultured and counted. When they brought to the laboratory, they make a cell count and all these cells are strictly subjected to all these microbiological tests, viral, fungal and bacteriological tests to show that they are free from any infection. Initial cell count we know.
AKIO in rabbit models, how do you take biopsy of these? Your histological pictures are very good, showing differentiation between transitional epithelium and squamous epithelium. With what instrument do you use to take biopsy? Out of curiosity, I'm asking how the research is done in rabbit.
Biopsy from the mouse, do you mean?
After the injection result to assess.
Just sacrifice the urethra, for urethra from the rabbit.
Whole urethra.
For urethra, yes.
Oh.
Rabbit has
No,
got
not
short
biopsy. But in case of human, it is not.
Yeah. So entire urethra you have sent and then analyzed what has happened.
Yes, and we mark the lesion of the injured urethra and cut continuous cut of the specimen, and four section was observed.
You have done immunohistochemistry, no, Dr. Horiguchi?
Yes.
Of the cells. You showed that the CK3 were positive and GATA were negative.
Yes.
Yeah.
I can. Yeah.
And and both of you, when you went inside with the urethroscopy, have you seen any change in the external appearance at the site of the OIU, where you have imagined that the cells have grown? Normally, when you do urethroplasty with buccal mucosa or skin, when we go inside, we can identify the luminal appearance of normal transitional epithelium, buccal mucosa, skin. Did you identify any change in the bed where you have injected the cells?
Yes, Chandramohan. From that site, I took a biopsy and proved that it is buccal epithelium. He showed in one of the slides the
So you have taken biopsy, punch type of biopsy, something like punch biopsy?
With the forceps, cystoscope, through the cystoscope.
Forceps you have taken.
Cold cup biopsy we have taken. And we proved that they are buccal epithelial cells.
In the future, AKIO, in the future, if this type of cell culture is cost effective or it costs a lot in the lab, how much it costs to produce that cell line culture?
Yeah, actually, we don't need to use not expensive materials. It could not be so expensive. So we are not planning to make some buccal mucosa seat. We just making culture. It is not expensive. Could be very moderate.
Yeah. Compared to the extensive urethroplasty surgery, this will not be.
Is it this type of cells in future can be made artificially, not from the patient tissue, so that they are freely available online, so that even if the failed patient will not feel bad? Is there any possibility? For example, now few days back we have seen that motherless wombs are coming for the support of the fetus. Cell cultures are available. So can these make artificial cell cultures of buccal mucosal cells to be implanted, used anywhere with anybody, irrespective of the patient? Can we use this type of cell culture?
I don't know. I cannot expect, but because we take only very small amount of buccal tissue, and even if the patient failed, another specimen can be harvested. It is not different from the urethroplasty. When in urethroplasty, we need to harvest very large amount of buccal mucosal tissue. So in failed case,
this can be done under local anesthesia. No? Everything under local anesthesia.
Yes, exactly.
Patient can go home after. Catheter has to be kept how many days then? In human beings, for example, Surya Prakash has injected today, and it forms fibrin. To stick it to this tissue, after patient voids, it may wash off. So, common question I am asking: how many days the catheter has to be kept then?
We kept for 3 weeks.
3 weeks. Oh. Then you remove it and watch for some time.
And then no CIC is the result of success. If you to say that the procedure is successful.
There are few questions are also asked. If you take patient small urethral tissue and culture, can it be used? Can normal urethra can be cultured like that? We don't know. Normal urethral tissue also can be cultured.
But you should not injure normal urethra. You should not create a stricture by taking.
By taking the. It's difficult.
Easy to harvest buccal mucosa. That is the reason why we harvest buccal mucosa.
Okay. Do you think that Surya Prakash, this type of research, I mean, last couple of questions, do you think this type of research will be helpful in the future, practically?
I hope
Both of you.
so. I hope so. I
I
think
hope
final
so.
comment is from Dr. AKIO. He should tell. He's the person who is the animal extensive research. Yeah, Dr. AKIO.
Tell Akio.
Yeah, we are just proceeding to the clinical trials, and almost animal data is completed, and the next step is clinical research. And we plan with Dr. Abraham to proceed with some urethral stricture patient. There are a lot of needs from patient when our clinical trials begins. Many patients asked me when we can start the clinical trial. So I think it is hopeful.
You will be the pioneer in this study, Dr. AKIO.
Thank you.
Yeah. It will be interesting, but definitely science will progress towards this type of investigations. Fibroblast culture, I think a lot of research is going on. I think epithelial cell line is not far away, but how far clinically it is useful, only future will tell. Anyway, nice to be innovative. I hope you will not become scientist. You will stay with urethroplasty surgery. Akio,
Yes.
you enlighten us in the future about this subject and keep continuing the urethroplasty. In your buccal mucosal urethroplasty surgery, pan-urethral stricture, what is the technique you follow?
Yeah,
Is it the same like Kulkarni technique?
Yes. Yes, I always use the one side dorsolateral only by Kulkarni technique. I always use his technique.
Do you have any experience in post-hypospadias failure buccal mucosal urethroplasty? Any in adults?
Yes.
Those who present in adults?
Yeah, we actually do a staged procedure, and first grafting at the first stage and second stage tuberalization. This is
in buccal mucosal graft staged urethroplasty, by chance, if you do you think that the graft survival, dryness, contraction, and before we go to the second stage, do you need to keep it wet or not necessary? I mean, if you do buccal mucosal graft two-stage urethroplasty, any experience?
Yes, I have both. We generally do grafting in the first stage, but in some cases do grafting in the second stage, just before tuberalization.
I'm asking, if you do in first stage, how are the results?
Yeah, it's not bad. We are very careful about the taking care of graft by using the moistening cream and keep hygiene. Yes, the result is not good. Not bad. Very good.
So last question: if buccal mucosa gets exhausted, what is your second choice? Lingual mucosa?
Yes, lingual mucosa is the second choice.
Have you ever used other than these two?
Yeah, actually, I use foreskin graft if the foreskin is available, but I have no experience other than the foreskin or mucosal graft.
Now there is some controversy of foreskin inlay graft versus buccal mucosa. Naturally, buccal mucosa is most favored, and a lot of articles are seen. What is your opinion, Surya Prakash? Do you think that the skin, in the absence of buccal mucosa, can be used if at all foreskin is present?
Next to buccal mucosa, foreskin is a reasonable option.
Reasonable option. Both have limitation, contraction and failure are there. So these type of cell cultures may have in future, at least in those cases who are suffering, who cannot be done again and again surgery. That's what I am understanding, that unless the research is done, they will become cripples. So with this, I conclude my talk, and I thank Dr. AKIO and Dr. Surya Prakash for joining. Definitely, this was totally new subject for me. And in fact, I am the best beneficiary today. Thank you very much.
Thank you very much.
Thank you.
Thank you, Chandramohan. Chandramohan, I would like to appreciate you really for doing these programs. In this digital era, I think you are spreading knowledge. You really need a big applause. Thank you, Chandramohan. Thank you.
See you next time in India.
Thank you.
Okay.